let's sort of now move a little bit into the metastatic space. Let's just, as an example, let's say we have a 57-year-old gentleman. He's got a Gleason 7 and very high PSA. And all of you, as you've mentioned, would order a PSMA, PET scan for him. And let's say it shows, and you're fairly convinced about it. Let's say a small number. Let's say three lesions. Let's say 3 bone lesions. How would you approach a patient like that? What would you talk to him about? And we'll talk about some of the trials and things, but just to kind of set the stage with, of course, with the STAMPEDE trial, we know that they have talked about potentially, and being a radiation oncologist, on that trial, of course, abiraterone in these diseases, in this setting, and on the STAMPEDE trial, they had a number of criteria, whether it be Gleason 8 to 10 or T3 patients or PSA more than 40. Those seem to suggest what sort of the NCCN would call a very high risk category. Those would seem to suggest that they might benefit from like a second generation anti-androgen, ARPI, something like that. But let's say it's a small number of lymph nodes or metastasis. Let's just stick with bone metastasis for the moment. How would you approach that patient, and how would you talk about the radiation, which of course, as we know on the STAMPEDE trial, has shown that radiating the primary site seems to improve prostate cancer survival?
I mean, with low volume metastatic disease, with a Gleason 7, I would tend to shy away from upfront chemotherapy. I think that would be overkill. We are definitely more aggressive radiating oligometastatic disease and the primary, even when there's metastatic disease now. So it's always a hard conversation with somebody young, because they kind of come at it with I want to be the most aggressive that I can. And you have to dial it back a little bit and just explain that it's not really necessary.
Gotcha. Anything to add, Jose?
No, I think you did mention it was a PSMA positive, so
Yeah.
I think
With a high PSA.
with a high PSA, and so I think if you're at academic centers, you may find the purists that say no, that the trial was only in conventional imaging, and so maybe we're upstaging. Does it make sense to treat these lesions? And I agree with Scott, is that we tend to be on the aggressive side. Obviously, you don't want to go to over-treating, right? You don't want to give additional toxicities that may not be necessary, but you do want to, particularly in these metastatic diseases, you want to, one, provide a hope for cure, because we've treated so many patients at our practice where, those single lesions or those 2 lesions that got zapped with radiation, and then they got, ADT and something like abiraterone or darolutamide, you see prolonged, remissions or PSA responses. And so you want to give those patients an opportunity. So, I think that the field will eventually catch up and we'll have those PSMA studies. But I think for now, I think I err on trying to give the patient the best possible outcome, of course, minimizing toxicities.
Yeah, what do you talk to them about in terms of side effects of the ADT and or the second generation anti-androgens that you might use? And I don't know, we can talk about, and we'll lead into the discussion, talk about the different kinds of second generation anti-androgens in a minute.
Yeah, so, I think of course, you want to give the patient the best chance for the best outcome, but you really have to be careful in tempering those discussions as well on what to look out for as far as toxicity. With the ADTs, the general side effects of essentially lowering the testosterone, that hypogonadism, the changes in their muscle mass, the changes in sexual function.
Very important.
Yes, and some, things, essentially male menopause symptoms that they have to be aware of. And oftentimes a lot of these men come with family. So I do counsel them that, look, there's going to be some expectation of some mood changes. So be self-aware of that. The partner has to be aware of that so that hopefully it doesn't ruin relationships. You know, and then the long-term use of ADT, I think we always forget the cardiovascular health, you know, the bone health aspect of it. Sometimes we're so focused on the cancer, but there are all these unintended consequences from these drugs. And then with the ARPI, again, you know, the cardiovascular risk, and I think the mental fogginess, you know, the sort of chemo brain that we tend to see with our cytotoxics, we do see them with, you know, the fatigue, the asthenia, the cognitive dysfunction that you can see with these drugs. They just have to be aware of that, because sometimes it's kind of like a slow boiling frog and people get used to it, but there's already a change that is noticeable to the people around them. So.
No, absolutely. It's, as we all know, and we've all had patients where, you know, putting them on ADT, it's a very low, you know, risk of getting a heart attack or a stroke, but I think we've all had patients that that unfortunately have developed those side effects. Laura, when you see these patients and they're starting to get their ADT or their second generation angina, what do you focus on with them?
Well, with the ADT, I monitor for, you know, the hot flashes, which become probably one of the biggest talking points in the exam room. And I can, you know, use some humor to relate to them about it. And then offering them maybe some medication like a gabapentin or venlafaxine to help treat those side effects so that it's more tolerable. Also, I tell them there are side effects from things like abiraterone that they don't see that we're monitoring for. Things like elevation of liver enzymes, low potassium, elevation of their blood pressure. So when they're coming in to see us, that's a big priority for us to monitor those things. And then the anemia that will develop also, a very mild anemia from the testosterone deprivation, giving them sort of anticipatory guidance about that. So even when they go to their primary and the primary says, oh my goodness, you're anemic, what's happening? I say, this is what we expect. And so giving them guidance about those things is important.
Perfect. Yeah, I mean, as a radiation oncologist, of course, you know, we have a number, most of them phase 2 studies, things like the Oriole study and on the STAMPEDE and on the HORAD study. All of those studies shown that radiating the prostate, they didn't look at the METs, the low volume, like the oligometastases. They didn't look at those particular studies, but they did show, and all those studies, maybe the HORAD didn't quite show it, but in a subgroup looking at, there was suggestion of a progression-free, at least survival with radiation to the prostate. So I think, you know, there's a lot of good, compelling phase 2 data that is an important treatment option for patients to at least to have a discussion with a radiation oncologist in the oligometastatic site. And of course, in the PEACE-1 study, radiation was also included in that as well, and that showed some improvement in terms of overall. While it didn't improve over survival, it did show some improvement in other secondary issues. Let's briefly talk about now, just to clarify too, with, you know, on the charted study, they did have the definitions of low volume and high volume being visceral disease, more than 4 metastases, one of which had to be outside of the spine. Does that definition of low volume and high volume, do you stick strictly to those discussions, Jose, let's say, when you're looking at deciding on chemotherapy or just hormonal therapy in the, let's say, castrate-sensitive space, so somebody recently diagnosed with metastatic disease?
You know, by and large, you know, you use that as a framework to work out of. You know, sometimes you'll find that patient that has maybe, you know, 3, but, you know, the third lesion is, say in the lung, right? So that would be a visceral met, you know, something that we saw in the Latitude trial. So they included those visceral mets. So I think, you know, if they're, you know, maybe relatively low volume disease, you know, where they're just maybe tiny little specks that maybe aren't well characterized, maybe you won't give them chemo, right? Because you may be overtreating them, and you may, rely on the ARPI to do the work along with the ADT, along with maybe with some radiation, right?
Absolutely. The Orto trial, one of the trials that looked at radiating oligomets, shown to see some improvement in prostate cancer progression-free survival, at least.
Yeah, so I think it's like, I tend to use the 80-20 rule a lot. So I think 80% of the cases, yeah, you're going to stick to that framework, but then there's going to be probably that 20% that fits a little outside of that, a little bit inside of that. And so I think that's the value of personalizing, working with your colleagues, working with the imaging folks, so that you get the treatment, as right as you can.